Assalamu alaikum, everybody. And I would like to thank actually really the people who did the work. I'm just here as the pretty face just to kind of present. Diabetic neuropathy and diabetic foot, as you know, is the most important microvascular complication. So we don't really know whether we should be using it to stratify risk of glycemic outcomes. And we've had then the opportunity when Mohammed rang me up and said, we've got this amazing data from the global survey. Would you like to have a look at it? I said, okay. So, to be or not to be, that is the question. Or I will say, to fast or not to fast, that is the question. If you have diabetic foot, but diabetic foot, not just, so what we try to do is say, okay, people without neuropathy, apparent neuropathy, but most of those will have some degree of neuropathy, people with recorded neuropathy, whether it's painful or painless, and then people who've got a foot ulcer attributed to predominantly diabetic neuropathy. So these are the demographic and metabolic characteristics of these patients. You can see less females actually in the diabetic neuropathy and with diabetic foot. Age is comparable. The duration of diabetes you would expect is higher in those with diabetes with diabetic foot. HbA1c is also higher. But other risk factors like BMI, systolic, diastolic blood pressure, LDL are comparable, and that is because they were on more treatments to adjust for this. If we look at the medications, I think that's important because we're going to talk about outcomes, glycemic outcomes. And I think a key difference is really, if you look on the bottom row, which is any insulin, and you can see that people who've got diabetic neuropathy or diabetic foot are clearly on a greater proportion are on insulin, so 72% as compared to 38%. The other drugs, pretty comparable actually, not much difference in them, even though there are apparent significant differences, not really. So that's, I think, the main driver. If we then look at, Bashar presented the retinopathy data, but what you see is that the presence of neuropathy, and particularly diabetic foot, I would say mirrors what happens in terms of the other microvascular complications. So the more severe the neuropathy outcome, i.e. with the diabetic foot, the higher the proportion of people who've got, say, retinopathy. But hyperlipidemia, hypertension, pretty much comparably controlled. Higher than those without diabetic neuropathy, but nevertheless comparable between those with diabetic neuropathy and diabetic foot. And you also see in the bottom column, macrovascular disease. Those with foot problems had a greater proportion with macrovascular disease. So then if we look at the main primary outcomes, which are essentially whether or not they fasted during Ramadan, and then if they fasted, whether they got daytime hypoglycemia, they broke their fast due to hypoglycemia, they had severe hypoglycemia and requiring medical attention, hypoglycemia, and then breaking the fast due to having severe hypoglycemia. So if you look, people without diabetic neuropathy, 88% fasted. If we look at people with diabetic neuropathy, 78% fasted. And you can see there is a progressive reduction in those with diabetic foot. There were less, but still, I would say the majority of people, even with the diabetic foot, are still fasting. What happens in terms of their outcomes? Well, daytime hypoglycemia. This is, and I'll show you the odds ratios, but you can see, just looking numerically at the numbers, 13% compared to 24%, 24%. So there is an increase in the in the incidence of daytime hypoglycemia, and it's actually comparable between those with diabetic foot, which you would say is more advanced neuropathy, and those with just diabetic neuropathy, but it's almost double. Breaking the fast due to hypoglycemia, again, no difference between the two DPN and DPN and diabetic foot group, but clearly double the amount that is present in those without neuropathy. Severe hypoglycemia, however, no difference. Hyperglycemia, again, twofold increase almost compared to those without diabetic neuropathy. But again, no difference between those with diabetic neuropathy and diabetic foot. So if we're going to have a stratification, maybe actually just having diabetic neuropathy is going to be sufficient. Breaking the fast, again, you can see increased, maybe almost threefold, but again, no difference between those with DPN and those with a diabetic foot. And severe hypoglycemia, again, increased twofold, maybe actually threefold, but again, no difference between the two groups, either with just diabetic neuropathy, which is, you say, oh, this is just a bit of pain, bit of sensory loss, but even compared to those with diabetic foot. So if you look at the odds ratios, which have been worked out, what you see here is fasting during Ramadan. So those with diabetic neuropathy, you can see they pretty much fasted, right? There wasn't a real reduction. There was no significant reduction. However, those with diabetic foot, there was a 50% reduction in those who fasted. And despite that, those who fasted, you can see they had double the complications. Again, Bashar talked about the bias, so I think we need to take that into account. And then if you look across the board in terms of whether it's hypoglycemia, breaking the fast due to hypoglycemia, you can see the odds ratios are all, 1.5 to threefold increase. So severe hypoglycemia, you can see was threefold increase, but comparable between those with diabetic neuropathy and diabetic foot.
Yeah.
So in terms of trying to find out what could be the reason why these people had more hypos or hypers, was it they had more or less education? Were they perhaps not measuring their blood glucose as much? So we again looked at the data, and first of all, the top boxes are, did they do SMBG during Ramadan? So was it more than before Ramadan? So if you look, patients with diabetic neuropathy were actually doing more SMBG than they were before Ramadan, but those with foot weren't. So despite having a higher proportion of people who were doing glucose assessment, they were still getting more hypos and more hypers. Less than before Ramadan, again, really, the DPN group were not doing less than before Ramadan. Same. Education. Actually, in terms of education, pre-Ramadan education, only about 60% of people without diabetic neuropathy received education. And this was actually lower in those with DPN and comparable in those with diabetic foot. So maybe that's part of the reason why the risk of having hypo and hyper was comparable between DPN and diabetic foot. And most of this education actually was given in routine clinic, although, and then in-group sessions very, very minimal, and leaflets were given, again, was comparable. So the majority of patients fasted, although those with DPN, and especially those with DFU, fasted less. There was an increased incidence of hypoglycemia and also hyperglycemia in those with DPN. I would say especially DPN and with diabetic foot, but actually it's pretty comparable, despite the fact that those with DPN were doing more SMBGs. And both DPN and DFU received less education, but particularly those with DPN. Thank you.